For this objective, the activity limitation is ambulation. The participation restriction is walking around college campus to class. The body structure and function is lumbar spine. Pain level is a 3 out of 10. Past medical history, the patient has had an L5 fracture and currently has a diagnosis of spondylolysis. Prior level of function, the patient was independent and was able to have pain-free ambulation without any time or distance limitations. And the following video shows the patient's gait pattern and the numerous deviations associated with it. Because the patient has pain, we conduct an OPQ-RSTU assessment. So the patient is a 20-year-old male who presents to PT with low back pain that has been ongoing for 2 years. He reports that the pain stays localized to the low back. He describes the pain to be deep ache and does not radiate down the extremities. At its worst, the pain is described to be a 3 out of 10 when performing movements such as walking and lying on his back. At its best, the pain is described to be a 0 out of 10 with no movement. The patient states that the pain is not dependent on any time of day and that the pain prevents him from ambulating for prolonged periods of time when walking around his college campus. So for the column 1 screens, when looking at a standing posture, left ankle supination was observed as well as an anterior pelvic tilt. Palpation-wise, the left lateral quadriceps were tender to palpation. There was hypertonicity in the left hamstrings, bilateral adductors, and left glute max. There was also multifidus atrophy in the left L5-S1 spinal segments. Sensory-wise, he has intact sensation to light touch, proprioception, and kinesthesia in the bilateral lower extremities and feet. Range of motion-wise, there was limited left active hip abduction. There was limited active and passive left ankle dorsiflexion. There was limited active right big toe extension. And there was restricted left calcaneal eversion. Strength-wise, for gross strength, there was weakness in the left hip abductors and right big toe extensors. In the myotomes, there was fatiguing weakness in left hip abduction and right big toe extension. Reflex-wise, there was hyperreflexia observed bilaterally in the patellar tendon, and the Achilles reflex was normal on both sides. He had a normal balance assessment, and for special tests, he tested positive for the Trendelenburg test.
For column 2, the functional task was ambulation, and we observed a right hip drop during mid-stance, excessive right ankle eversion during swing, a left knee varus thrust, a lack of left ankle dorsiflexion during mid-stance, and lumbar pain. Our modified task was left initial contact to left mid-stance, and when we applied the method, we found stabilization helped at the hip, reducing right hip drop, reducing the left knee varus thrust, and reducing the right ankle eversion during swing. Motor control helped at the lumbar by decreasing lumbar pain, and a BMC worked at the ankle. The posterior talus glide improved left ankle dorsiflexion. We added some pictures so you could visualize what we observed. So during mid-stance, we have the right hip drop. We put the red line so you could visualize that. Here's the excessive right ankle eversion during right swing. And then this is the left knee varus thrust. And here during mid-stance, you can see the lack of left ankle dorsiflexion.
For column 3 in our breakouts, we performed a strength breakout of our left hip abductors. At mid-range, there were 4 minus out of 5. In a range, they were weak and unable to hold. Throughout range, they compensated with the TFL. Our strength breakout for right big toe extension, mid-range was a 3 plus out of 5. Inner range was weak and unable to hold. Throughout range, unable to get into the inner range. We also performed a range of motion breakout of the left ankle of dorsiflexion, and the active Goni measurement was -4 degrees dorsiflexion. Passively, they had 2, and the structure barrier was firm and non-yielding end feel with no glide present. We also did a range of motion breakout of right big toe extension. Active Goni was 35, and passive would being 50 degrees of extension. And the structure barrier was firm, yielding end feel with the glide present. So for the stabilization breakout of the left hip, static balance was 22 seconds with contralateral before the contralateral hip drop, and dynamic was 14 seconds before that occurred. For motor control of the lumbar spine, throughout range was normal and full anterior pelvic tilt to posterior pelvic tilt. Inner range was strong, and for dissociation, the anterior pelvic tilt give was seen after 20 seconds of bridging with marching. So for our final assessment, we had patient is a 20-year-old male presenting to physical therapy with complaints of pain during ambulation. He reports a 3 out of 10 lumbar spine pain after walking for more than 5 minutes. Patient presents with a right Trendelenburg, left knee varus thrust, and excessive right ankle eversion when transitioning from left initial contact to left mid-stance. Examination reveals left hip abduction and right great toe extension weakness, along with limited passive left ankle dorsiflexion and right great toe extension range of motion. Patient has a possible anatomical diagnosis of functional stenosis due to pathomechanical diagnosis of an instability at the L5-S1 segment, causing excessive side bending and closing of the IFE space, driven by decreased left hip stability and lumbar motor control. The above impairments limit the patient's ability to participate in activities of daily living and school-related tasks, and the patient would benefit from skilled PT services in order to address the above limitations to return to functional activity symptom-free.
So we came up with the following goals for our patient. In the short term, at the 4-week point, our patient will increase left ankle dorsiflexion range of motion to 10 degrees in order to allow proper tibial anterior translation during mid-stance for improved gait mechanics. Our second short-term goal would be that the patient will increase right great toe extension to 60 degrees to facilitate proper activation of the windlass mechanism for effective push-off during terminal stance and pre-swing. For the long-term goals, at the 8-week point, we came up with that the patient will improve left hip abduction strength to 5 out of 5 in order to ambulate 1,000 feet without right hip drop, thereby reducing shearing forces on the lumbar spine. Secondly, the patient will increase their endurance of the L5-S1 multifidus during the prone multifidus lift test from 10 seconds to 30 seconds in order to prevent excessive translation of the L5 vertebrae to allow 20 minutes of pain-free walking. And our last long-term goal is that the patient will improve great toe extension strength to 4 plus out of 5 to facilitate toe clearance during right early swing phase in order to reduce the right ankle eversion compensation. To achieve these goals, our patient will come into physical therapy for 2 times a week for 8 weeks. Manual therapy for this patient would be involving in mobilization with movements for ankle dorsiflexion. This would be performed 3 times 10, each with a 2-second hold, and this would be performed in order to increase left ankle dorsiflexion range of motion. Our second manual therapy technique would be a grade 4 dorsal glide to the first MTP joint on the right side. This would be performed 4 times 30 seconds, and this again would be to increase right great toe extension range of motion. In terms of the exercises this patient will be performing, they will be performing side steps with a TheraBand around their ankles in both directions for 3 times 10 steps, again in each direction, to improve left glute med strength. The second exercise they'll be performing would be the side planks with the left side facing the ground, 3 times 10, and with a 3-second hold once they lift it up into that side plank. And this again would be to improve left glute med strength. Thirdly, the patient will be performing a supine bridge with a march while maintaining a neutral spine. They do this for 5 times each 20 seconds to improve lumbar dissociation. The patient would also be performing right hip flexion while maintaining the great toe in extension while a TheraBand pulls the great toe into flexion. So what this would look like would be the patient would be moving their right hip up and down while TheraBand is trying to move their great toe into flexion, and they would have to resist that. So they'd be performing resisted extension for 3 times 10 each 3-second hold, and this again would be to improve right great toe extension strength. The patient would also be performing single leg stance on the left side while maintaining a neutral pelvis and lumbar spine, and we'd be monitoring for a hip drop, and then they'd be performing this for 5 times 20 seconds to improve left hip static stability. And then to work on left hip dynamic stability, the patient will perform a single leg stance, again standing on their left leg, while the right foot is moving and tapping cones 10 times 10 seconds. And then in terms of therapeutic activity that we'll be performing with this patient, we'll be performing part training, focusing on the left limb going from initial contact to mid stance, while the right limb is going through swing phase, and the right arm is raised to about 120 degrees. This is to activate the left multifidus, and they'll be going through these from initial contact to mid stance for 10 times 10 seconds each. Thank you so much.